All right, my name is John Russell. I'm a nurse practitioner, and I work in cardiothoracic surgery. Just want to say thank you for being here tonight. We're going to be talking about the APRN and the OR, and I say it's a whole new world with this picture just because, quite honestly, part of being in the OR is it is truly a brand new world for a lot of people that are APRNs that have never been in the OR, and their first exposure going into the operating room is in that first time in, let's say, a surgical practice or a general surgery, CV surgery, ortho, whatever it is. Was welcome to this whole new part of your job that's truly a second job if you're in the OR. So we're going to talk about that looks like, what that could be beneficial to you, or what the changes can look like. So just, there are lots of things that go into that. I am a nurse practitioner in cardiothoracic surgery, and I have been fortunate to have a good relationship with NIFA for quite some time here. I work as the program director for the college division, and I am the owner and CEO of a company called Skills on Point, which you may have heard of. Do a lot of procedural and privileging training going throughout the country to schools and providing standalone courses, kind of in coordination with NIFA. So not really the first assisting content, but all the other procedural and privileging things you need to be in the hospital. And I am a founder and president of a company called Mission Skills, which is a 501c3 nonprofit. And we do a lot of work helping people have access to skills for no or very low cost if they're going to go into medical service missions. So it's kind of where it's at for us. We try to do as much as we can to give back. So what are we going to talk about tonight? We're going to talk about, first and foremost, just the introduction to the ORs and the APRN, what it's like, what are the things you can expect, what are some of the things that I've gone through that maybe you'll resonate with if you've already been kind of pushed into that role, and you can kind of say, oh yeah, that's true. Or if you're not yet, you can kind of anticipate that and use it to your benefit. I'll talk about how your skill level will affect your employment, and I'll explain what that means a little more as we go along. How billing works for procedures, which certainly is not meant to be a standalone discussion just about billing, but I think it's important to understand how you as a APRN working in the OR have a different role than a RN or a surg tech FA, or just different possible scenarios where you might be in that role will look, and how that can work to your benefit. Again, we'll specifically talk about that RNFA versus the APRN RNFA billing. And this is kind of a flux of things that are always changing, and every state's a little different, but my goal is to give you a little bit of a lowdown on that. Negotiating your RNFA training based on your billing plans, and not to be really hitting it heavy on the billing thing, but honestly, your ability to negotiate what you bring to the table is based a lot on what you're going to bring as repayment. So it's all kind of tied together. And then at the very end, we'll have a question and answer time where you can kind of just go at it and let me know what you think. Feel free to tell me, what you're experiencing, good, the bad, the ugly, and hopefully I can help. We can kind of help each other out as a group here. So first and foremost about me, I was in the Air Force from 01 to 07. I was a paramedic kind of halfway between there. And kind of that got me into the whole medical field. Really enjoyed pre-hospital medicine and emergency trauma. Became a registered nurse with an associate in 2008 in the ICU, and got a bachelor's doing the same kind of thing, a little more with hearts thereafter in a critical care CV surgical area. And then I went straight into a FNP program with a master's, and graduated in 2014 in CV surgery. And the reason I mention all these things is not because you want to know about my curriculum vitae, but I want you to understand that I do represent somebody who has gone through this, from the beginning through into when I actually started in CV surgery. I had no OR-based training. So I am one of those people that is the poster child of saying that if you're going to go through training, it better be good training, because it's all you have. You don't have 10 years in the OR as an RN to stand on. I mean, you walk in the OR and this is it. It's brand new, day one. So it's certainly something that I can say is it's doable. You can survive it. There's a steep learning curve, but that's part of the fun. I went through NIFA to get my APRN RNFA in 2015, and I absolutely give that credit to kind of steam catapulting my career forward into the procedural and first assisting role. And I can tell you that it certainly made the difference in my ability to negotiate more in my employment. I got my DNP in 2016 and started Skills on Point as kind of part of that was a need for seeing access to all those different skills and trainings that kind of go in addition to NIFA, and kind of all the the catch-all basket of things you need to be, let's say, a CV surgery nurse practitioner or a general surgery nurse practitioner or say primary care nurse practitioner. They all have different list of things you have to kind of check the boxes on and be competent in. And we wanted to make sure that that was something we could help support, because I had a hard time finding all those things. So we've made it more of a streamlined process with really high quality content. And then we started our nonprofit branch in 19. I worked more closely with NIFA in 19 on as the program director and also an instructor for some of the Suture Star workshops. And then I went back for my adult geriatric acute care since I was an FNP and a surgical practice. Just with the trend of all the things going on, I felt it was appropriate to go back and just get dual boarded. So I was family and acute care. And I did that through UPenn in 2020. So I can tell you since 2001 on, I've been a student, and I'm glad to finally be done. I teach as an assistant professor at a CRNA program now and for a couple other FNP programs. And I really enjoy just seeing all of that kind of come together. So that's enough about me. Let's talk about what the OR is like as an APRN. So I speak all of the last slide about me, just so you kind of know, like, this is where a lot of people find themselves somewhere on that trajectory. And I have given this talk multiple times before. And routinely someone says at the end of it, like, oh my gosh, I see myself, like if that's 10 steps, I see myself on a 7 or a 4, or like I can put myself in your shoes. So I just want you to realize that wherever you're at, like you can keep on going. There's always something more. You can always push to the next level, and don't feel like you shouldn't be doing that. The RNFA is a perfect example of that. A lot of people look at being an RN or APRN, and they say, well, that'll be good enough for me. And they're in an opportunity that people would kill for. And they're like in a surgical practice, like a CV surgery, gen surgery, whatever. And someone says, hey, I'd like to have you come to the OR with us. That is such a unique opportunity to have someone who's gone already that far to say, we want to invest in you to be in the hot seat. And if you say no to that, that's really hard to have another swing at that opportunity. So my encouragement is, if you have that in front of you, don't be afraid of it, attack it and say, I'm going to do this, because you can always change, go somewhere else, do something different. Once you've got that credential, that credential is after your name, you're set. So just my 2 cents of advice. So anyway, you walk into the OR, you see this picture like you see in the backdrop here. You got the lights, the table, the floor, everything looks sterile and just, like, oh my gosh, don't touch anything. And meanwhile, everyone's looking at you like, I have no idea what's going on. Everyone else knows what's going on. Where should I go? Where should I stand so I don't touch anything? And everyone's just judging you and kind of waiting for you to make a mistake, because it's part of the deal. Everyone's kind of looking at the new guy saying, oh yeah, this is going to happen. You're going to touch that without the gloves on, or you're going to contaminate, or something's going to happen. But we all make those mistakes. And obviously the whole point is making sure that we don't have patient safety issues. But do realize that it's a hard jump from APRN to the OR because you've never been there before in most cases. And the other part about this too is just realizing there is competition for that seat at the table. This is a very esteemed opportunity to be at the first assistant. And that may vary depending on where you're at. I've known a lot of people that said, oh yeah, there's residents and attendings, and there's interns and fellows, and there's all these different layers of people that are going through some level of training, and they have to get dibs in there, and they jump ahead of you. And because of that, you don't do as many reps, and it is what it is. They're always doing the closing, and you're basically just holding retractors. And then there's some people that say, we don't have anyone there. We don't have any residents. We don't have any fellows. And basically it's me for every single case all day, every day. So I guess my point with that is just realize that there's competition for that seat at the table, and it varies based on where you're at. If you are really hungry to get a lot of cases, then go to a smaller hospital and you will be utilized, but you're going to burn out faster. And then the alternative is you're also going to get more reps, and you're going to be much better at what you're doing. So there is a fine line there where you got to find what you're comfortable with and define what you're comfortable with, and also set firm boundaries, because that's really hard. If you don't have good boundaries, you'll get taken advantage of in those. So do realize there's a lot of people that love to be you, and you have to take that seriously. If you go in there and you're all joking and messing around, and no one's going to really appreciate the fact that you're there, they're going to be kind of sad that you're there instead of someone else who takes it really seriously. But that said, that's not you. Obviously, you're the people that you're gung-ho, you want to do it right, you got the right attitude. Why are you here instead of a Surg Tech FA or RNFA or a PA? And the question always comes up for that is, there is a reason they chose to hire you. And what is that reason? Well, it may be something as simple as billing, or it may be something more reflective of longitudinal care, where you can follow before, during, and after the care and do the office visits and education. I think it's very specific to the hospital system if you have PAs versus NPs. I think some of that is also geocentric around where there's PA programs or NP programs. And I think that's just, that's just part of the deal too. But it's convenient sampling as to how people are hired. So just realize that every hospital is unique in that. But I will say, we'll talk about this, some of why it would be beneficial for you as a APRN to be there instead of an RNFA, STFA, or a PA. So what are the drawbacks of being in the OR? I think one of the hardest things is if you're brand new, it's just a lot to take in. If you're learning how to just do the simple things like diagnosis and prescription and daily rounding, management, consults, discharges, like all the inpatient throughput. And on top of that, you have to do OR time, and you're adding a whole other skill set, maybe doing procedures. It's just multiple layers of responsibility and a lot of learning curve. So I think that's just one of those things where you have to be the kind of personality to really want that. But that said, the other drawback really is just the time, right? So if you're going to be in the OR in a position that's going to be a little bit more esteemed, which is the benefit there, the drawback is you're probably going to be on call a lot. You're going to have to deal with those rough hours, and it all just kind of, it comes at that price. But that said, the benefits, sure, you're going to get paid more money. You're going to have a cool, flashy title. You're going to be able to potentially have better transferability if you go to a different job because of the skill set you have. It is very unique. And those are all things that you have to decide how that impacts your decision. Everyone has a unique driving force. I think one thing we've learned in COVID is it's not always money, right? Quality of life, having firm boundaries and being able to do things that make more sense for your family. Or maybe for you, it's like, I don't really care about that. I'm single. I want to travel. I want to make as much money as humanly possible. Like, there's no wrong answer. It's just whatever makes the most sense for you. And there is a position for whatever of those options and whatever in between that you want to do. So my point is, it's a great opportunity. I would definitely recommend, if you're kind of on the fence about it, to do a FA role. That said, how your skill levels affect your employment. I hired in 2020, 2021, 2022. It's not going to change altogether too much. Going through a pandemic and seeing this, the way that has altered the way hospital flow is, finances, staffing. I mean, everything is a whole new world right now. I think there's never been a time in history that I've seen, and I can tell you because I work with a lot of schools and I hear the backstories of how things have always been, how they're going and what they're trying to do. The hardest thing in all of this is, and again, as being a student for the last 20 years, I can see it firsthand. It's hard to actually get clinical sites. It's hard to actually get into the training. It's hard to do, all the in-person classes and actually get your hands on the skills when you're not able to do that because it's all distance-based learning, right? So that's just kind of one of those downfalls that we've had to deal with of COVID. So the hard part about this is when you're basically a digital student going through a process and you show up on a piece of paper, and you're no different than anyone else that goes, let's say you have a class of 20 people. Of 20 people, you're number one. And you have 19 other people. Why would you be the person that they pick? And it may be GPA, it may be your extracurriculars, it may be whatever. Honestly, when it comes down to it, to me, if I'm hiring somebody, my choice is always going to be pick the person that can do the job with the fewest amount of question marks. The statistical success of somebody for the buy-in cost, because it's expensive to train new people. So if you want to stand out, how do you stand out? That's the big question, is what is going to put you above the other people? In my mind, the answer is it's all about your skills training. The reason I say that is because everybody is trained to the level of, if you've passed boards, you're trained to that level of expertise for passing certification. And you've trained through whatever your program is, if it's an FNP or an adult gero or CNS or midwife, you've trained through that process. So you have that skill set, that knowledge base, the didactic. But how good are your hands is always the question people say. Like, okay, we'll hire you, but how good are their hands? Like, how good of a surgeon are they? Like, what can they do? So that hands-on skill component is really where I think a lot of people, if you can have that vetted already, that puts you in a whole different category. It's not a question mark, right? I know that you're going to be able to do this because I've seen you do it. I know you're capable of it. And what that means to me is making sure that your program prepares you effectively for the job you actually want so that your skill set and your hands, quote unquote, match the role. You don't have to have the same hands for CV surgery as you have for gen surgery, as you have for neurosurgery, as you have for plastics. And right, it's all different roles, different cases, different, all of that. So you have to kind of find where you fit the niche. And the big question here is, how well were you prepared in your program? And that is really hard to answer right now, because every program that was brick and mortar kind of had this like, oh, we're better than the online programs because, we actually see our students in person and blah, blah, blah. And for many years, I think that was kind of the trend of what I was seeing, just anecdotally where I was working. There was kind of a hesitance of hiring people that were in an online training environment. And I can tell you that with COVID, that everyone's an online student now, right? So the schools that were already doing that understood that process, they actually did better than those that were brick and mortar, because the brick and mortar had no idea how to do that. So it was a learning process and a very quick learning curve for the instructors and the processes and the infrastructure. Everything went backwards. So all I'm going to say is, whether it's brick and mortar or online, the biggest question you need to know is which NP program is going to prepare you for operative medicine. And the answer is none of them. Not a single program out there is going to take you into the operating room and teach you how to first assist. And that's why going through a program like NIFA is where you're going to get that benefit of being prepared for the roles. So in CV surgery, I can do all the things that any NP can do. And I have additional privileges of, say, like central lines, chest tubes, art lines, intubation, whatever, pulling pacer wires, pleurodesis, and thoracentesis. There are all these different things. But that said, there still is one that says assisting in the operating room. And that one that's so unique to that is something that I didn't have as part of my school, because it's not part of any program. There are programs out there that will incorporate a first assist training into the program, not because it's part of your national scope of practice. It's a separate additional thing they're doing to try to make it into like a surgical NP thing. And that's totally fine. But that said, do realize that there's no certification, FNP, adult gero acute care, CNS, none of them cover going to the operating room and assisting in the case. So that's where you need something like NIFA. And that's why the notoriety of NIFA as being the leading edge of high quality training is why a lot of people choose NIFA, because you go anywhere and say, where'd you get trained? They'll go, oh, NIFA. I go, oh, okay, cool, got it. It really does have that kind of clout, and it makes it really simple when you want to move around. Okay, what else do you need to know for your position? Well, I just rattle off a list of different procedures that I do. So I can say the easiest way to find this out, if you know what you're going to be doing, if I say this as someone who has another NP coming onto our service, and they're going to be doing a role very similar to mine. My role is basically go to the OR, round, see patients, consults, do all that kind of stuff, and then do procedures as they present themselves. There's another NP that works and is not privileged into doing the procedure. She doesn't want anything to do with it. She wants to manage all of the outpatient valve patients, the structural heart stuff, the valve clinic, TAVR referrals, all that. I mean, it's a very different role than I have. And it's really complementary because we work well in that regard. But that said, I have another guy coming in that specifically wants to do what I want to do. So the first question he asked, it's a great question, is, can I see your privileging sheet? Can I see what you can do in your role so that I can make sure that I get the training that you're going to be able to do to look like you, not like them, because I want to do what you do. So there's no right answer for this. You just need to talk to the people that are doing the jobs that you want to do. Or if you know you're going to be, potentially moving to an area that has different scope of practice, and those are all hospital specific, you need to talk to people that are doing the job at the hospital to learn what that's going to look like, if at all possible. Now, there's always someone who says, well, hey, where I'm going to be, there's no other NPs. I'm the first person doing this, that no one really knows what this looks like. What am I supposed to do? And what I would just simply say is talk to people that are doing this job somewhere else, get a consensus opinion from different places around the US, and try to make sure your opinion matches what is close to that area geographically, and say, this is what I think is appropriate. And you're going to have the credentialing body say yes or no. It's pretty simple. So all I have to say, you need to make sure that you are proactively managing this process. No one's going to do it for you. And I've seen people that are NPs that were hired by a private surgeon. Surgeon said, hey, come work for us for surgical practice. We've always had PAs, but hey, you're an NP and I really like you. I want you to work with us. Okay, great. They get hired, not realizing that that credentialing process can take a long time, especially if the system is not used to NPs and they don't really know what to do with you. It can be painful. And my wife was in that. She was one of the first NPs to be a first assistant in orthopedic surgery. at a hospital in Northern Illinois, and they always had PAs. They've had plenty of assists, but they were just never NPs. So they had to go through a certain process to get things figured out. It took multiple months of the credentialing committee meeting and her just waiting and waiting and waiting. In the meantime, the surgeon said, okay, we'll hire you to start this day, like April 1st. And it was something like October or November by the time she was actually able to bill as an assist in the OR. So that whole time, she's not making hardly any money because she was on a salary based off of her productivity. So point being is those things happen pretty frequently. And unless you know what to expect and help navigate it, it gets very sticky very quickly. And that surgeon's probably not going to want to keep you around if you're not making any money for them. So you want to be ahead of the game and already have the documentation. The question always comes up, what positions are the most sought after and why? This changes everywhere you go, right? Geographically, this changes. But as far as first assisting, I think it's usually, if you're looking at this job, it's probably about the money. The best paying ones are going to be the ortho, plastics, CV surgery, spine, like neurosurge, like those are really well paid. Depends on what your type of employment or contracting relationship is. But those are pretty popular when you do the Knife of Suture Star workshops. A lot of people are doing CV, ortho, and neuro. Some plastics. All right, so real quickly, I want to kind of walk through this. I had no idea how billing worked for procedures just because, quite honestly, as a nurse, before I became an APRN, I had no idea. I just never needed to know, right? I was working in a critical care unit, seeing patients when they were already in the hospital post-surgery. So I never really had that understanding of how it worked. So just to kind of give you a little blip of this, you can imagine any patient comes into the hospital having some symptom. Let's say they come to the primary care. They come to the primary care having intermittent chest pain. They go see their primary care provider and they say, okay, well, I know you, you know me. Let's do some workup here. Let's do a stress test or let's do whatever. Get you scheduled to go see a cardiologist and do an angio or whatever. Workup is going to end up happening. There's an established E&M code that is existent for that outpatient visit. So like this is kind of a fee for service model that you'd have. You go get your oil change, you pay for your oil change, on you go. So that's the fee. There's a service. Have a nice day. Okay. Then we get this referral to the specialty or surgeon. And now we're kind of moving up the chain. And this is, of course, where you start seeing the prior auths, and the insurance will have something to do with this. It gets more expensive. And now they've gone to see the cardiologist. They're going to see him and say, oh, yes, I do believe you probably have true cardiac pain. You're taking these medications. And I look at you and I say, you probably have a heart problem. Let's go ahead and do a procedure. And this, again, there's going to be another E&M code there. There's a new consult charge for the visit. It's going to be a more expensive visit. And now we're kind of walking into that area where we're saying, okay, now we're looking at a big procedure and a hospitalization. And this is important as an NP. Insurance does their approval. They say, okay, these 2 days are the days you can do the surgery. And then you basically have the patient come in for an elective case, or maybe you're in the hospital, it's an emergent case or a urgent case. And then the procedure is done based on these visiting and imaging findings. It can take a couple weeks to get it going, but once the day of surgery actually happens, that's where it gets a little more interesting, right? The procedure is approved by insurance, is scheduled, and the procedure actually occurs. Everything leading up to this point, you as a nurse practitioner can bill for those visits, no matter if you're the primary care or you're the surgical specialty or you're ordering labs and testing, whatever it is, you can bill for that. Once the day of surgery happens, okay, that's where you kind of roll into this very unique process that is important for NPs to understand that we don't do a good job of understanding going in. Now you're in the surgical bundle, okay? From surgery on, for 90 days, you're basically in what's called a diagnosis-related repayment group, a DRG. Okay, so the surgical bundles are the name for that. What that means is anything that happens is basically, here's your lump sum of money that you're going to get as a hospital to take care of this patient from start to finish from the surgery. Your daily rounding, your daily management notes, whatever you're going to put in the chart, the discharge summary, all those things that you're part of. Post-op care, every single outpatient visit, those are all free. Well, they're all paid for, so to speak, but they're all part of the surgical bundle. This is where it gets interesting, because as an NP, and let's say you're part of a surgical team, obviously the surgeon is going to be getting that surgical bundle repayment going to them. You may get credit for being a first assist or whatnot, but all of that aftercare is free. You're not going to develop any diagnosis-related repayment income from that unless there's complications. That said, there's something called RVUs. It's a pretty common way for a lot of NPs and PAs to be paid, which is a relative value unit. So, you go see a patient, you get X amount of RVUs, and in the course of a year, you're expected to make, let's say, 1,000, 2,000, 3,000, whatever the number is. It's all different based on your specialty. If you happen to be an NP, and I have a friend who went through NIFA, is a first assist, works in obstetrics, she's awesome, but she got kind of suckered by this surgeon. The surgeon said, "Hey, I want you to come help me with my patients. It'd be great. I have an awesome clinic. I have an awesome surgical practice. We do a lot of, high risk obstetrics. It's awesome. You'd be great at this. You get a lot of time suturing. I mean, who wouldn't want that job, right? It's kind of cool. There's some call time with it, obviously, but it's very doable." Okay, fair enough. So first gig out of NP school, goes through NIFA, gets trained by an awesome person. As it turns out, that person basically said, "Oh, I want you to see all the post-op visits for me because I want to see all the new consults. They don't really want to see you, but you can see them after you've done surgery on them. Everything's better. They're healing. You're cool with that, right?" And she's like, "Oh, sure, whatever." Well, little does she realize that all those post-op visits are basically free visits. So she didn't actually earn any RVUs. And the same thing happens with me. Like if I go see a surgical patient in a consultation, sure, I can bill for that. Day of surgery on, all those daily management notes, which may take half or more of my day, are unbillable. So my point being is make sure that when you go to the negotiating table, you can say, yes, I would probably be pretty busy in my day, yet you'll have a hard time showing what I did for a living because you're going to be looking at RVUs as the benchmark. The problem is I'm not going to be making any. So you can't make me rely on RVUs to show my value. You need to have a salary or something, a surgical case volume or some other way to quantify the fact that you're a value add to the team. So my point being is make sure you don't get yourself suckered into doing something and then think, well, we were expecting 2,000 RVUs a year. You only made 1,000. So we're going to actually dock your pay. And you're busting your butt trying to see patients all day. And it's just because a surgeon wants to take all the easy billing. So this does happen. Just be aware of it. RNFAs versus APRN, RNFA billing. Again, this is kind of a blanket statement. Every state's different, and there is a lot of autonomy when it comes to the states as far as their insurance products. But do realize that there are some things that are more across the whole federal government. CMS, which is Centers for Medicare and Medicaid Services. This is, of course, the federal government with Medicare, Medicaid, and the states actually employ the Medicaid process of that usually. They do not reimburse for a non-prescriber first assistant. So basically, if you're NP, PA, or a physician, you can assist, or like a resident or something like that. But if you are a surge tech or a RNFA, although you're doing the same exact job, you can be better at the job. It doesn't really matter. They can't bill for you in most states. Now, I say most because every state's a little bit different. This changes, and for the sake of this being an accurate talk, just realize that your state is different than the next state and the next state and the next state. So you just need to know your state's boundaries with that. Now, commercial insurers mostly will cover RNFAs if it's an assistable case. Now, doing CV surgery obviously is going to be an assistable case. You probably need an extra set of hands to do a bypass. But that said, if you're doing, I don't know, carpal tunnel release or something, chances are probably not. Right? So it just depends on what the insurance quality is, what the coverage is, what the documentation is, how it all gets sent as a package, who sends what bills off first to be paid. These are all kind of things that can change whether you actually get reimbursed or not. Do you realize that APRNs are able to bill in all 50 states for CMS and commercial patients? So Medicare, Medicaid, commercial, Blue Cross Blue Shield, Anthem, Humana, like all these big names. However, it does depend on your specialty for certification and hospital credentialing policy if you're going to be allowed to even sit at the table. So whether you're an FNP or an adult geriatric acute care or CNS or midwife, there are different hospital-specific requirements for what is allowed versus not allowed for you to be credentialed. And a lot of the time that is based on what insurance will or will not pay in that state for that insurance product. So my point being is just talk to your credentialing body, talk to your med staffing office, talk to your insurance people and your billing people and say, hey, I'm this, this is me. I am this certification. This is what I want to do. Is that going to fit here? Is that going to make sense? And if it doesn't, find a place that it does, right? It's not to say that every state's different, good or bad. It's just that there is a fit for everybody. And there are plenty of places that have no problem with you being an FNP in the hospital. There are plenty of places that will have a problem with you being an FNP in the hospital. You just have to know which ones are which, right? Everywhere is different. And I think there is such a need for people to assist and help in the hospital with all of this COVID stuff. We talk about people that are leaving the workforce and people being burnt out. Like, there is just such a need. So I do think that there is some expansion happening here, but you will see some places being very specific about what they will allow as far as certification. PAs are currently allowed to bill in all 50 states because they are working under that medical model. And the AMA doesn't really want to fight as much with PAs because PAs kind of work with them a little closer. But that said, there is some full practice authority stuff coming for the PAs too. So expect to see some pushback there too. It's an interesting world right now, let's say. Also, do realize that if you have a hospital that does have those layers, we have like a residents and fellows and all that, the government is paying money to the hospital for them to be trained and also to use them as the surgical assistants and all of that. So if they're trying to bill for your services, they will have to have a one-liner that says, hey, there was no resident available. People say, what is that supposed to mean? That's what it means. That means that they have to justify why they didn't go find, resident Joe and say, hey, you're in. They said, no, I want to have this person because they're specifically trained to do the best case. Well, it doesn't really matter. If there's a resident available, you need to have them in the case, at least, walk in the room, put some gloves on and, hold a retractor for a minute and then they walk away. At least then they can say that they had them in there, but then they can't bill for the first assist. But if there's no one available, then they can bill for them. So again, it's games that are played. You've probably seen them. It's different in interpretation everywhere you go. My point being is just be very cognizant that this is a very fluid thing and you need to be aware of what your local hospital recommendations are. It's all based on the credentialing body in your hospital because they're the ones that have to interpret the malpractice insurance. And if that is misinterpreted, they can lose their coverage for everybody in the medical group. Okay, negotiating your RNFA training based on your billing plans. So here's my scenario. I'm finishing up NP school, and actually about a year before I was done with school, there was a PA that was in the role that I was interested in, and he decided to move on in his career and it left a hole. And I said, you probably don't want to wait a year for me to be done with school. But that said, I've been a CV surgery nurse practitioner, a CV surgery nurse, and we have a really good relationship. I love taking the hearts. I train people on taking hearts. I feel like this would be a good fit for me, but you're gonna have to wait a year until I'm done with school. So they said, we will wait for you for the job, but in the meantime, let's have you do some clinicals with us. Let's do some on-the-job training. Let's kind of have some job sharing or whatever. So it worked out just fine. But I would say part of that is you go to an interview. What do you need to be thinking about so that you can be thinking about how do I, knowing that CV surgery is my dream job, and I know what this person that was a PA in this role had, the things that he did, where he went to the OR and the procedures that he was able to perform and how he rounded, like I wanted to know what that looked like. I needed to kind of prepare for that. My biggest thing here is when you're about to interview, you're ready for this, plan for your training. Okay. This is the most important thing. And I've seen this backfire, and it always is like that one thing that no one told you that you wish you knew. Make sure you bring up going through first assist training in your interview. And why should you do that? Because I've seen people that didn't. And if they accept you into that role, sometimes you'll go through the gamut of about 10 different interviews in a day to go get hired as a mid-level, NP, APRN. People say, oh, don't say mid-level. It is what it is. If you're not a surgeon and you're not a nurse, you're kind of in the middle. So in that role, what do you do with that? You've interviewed with 17 people. You just either shake hands, and is it interviewing them, is it interviewing you? And then they're all kind of just part of the process. They kind of score you, but they don't really get to know you. Maybe one or two of those people are actually going to be in a decision to say truly yes or no. It's important that the right person that is your manager or thinking about the capital budget cycle is saying, I think this person's the right fit. And they're also thinking about what it's going to take for them to be successful in the role. If you just say, well, I'm here, I'll do the job, I don't care, whatever, that kind of shows that you don't know what it takes to be successful. And it's a question mark. And I don't want a question mark if I'm choosing to help hire and train on somebody else. I want someone who I already know has done their homework. They're going to say, yeah, actually, I already know that I'm going to need to go through NIFA. I already know that I'm going to have to pay for that and they take the time away from my work. I'm already aware of that. However, this is what the information about it is. This is the course I want to take. This is the location. This is the dates. Plan it out. Because if you throw it out there up front, there's a better chance that they'll pay for it and be able to at least roll it into the next capital budget cycle if they haven't already accounted for it. Whereas if you don't say anything, a lot of times they'll say, well, you didn't ask for it, so nope, too late. So just make sure you bring it up front. I myself did bring it up in the interview process, and they planned an additional week away from my work with being paid. They didn't take any of my vacation time, especially as a new grad, I didn't have any vacation time. And they also accounted for the entirety of the cost of the program, the airfare, the hotels and everything. So it was a really nice thing to do, but they had to wait until the next capital cycle because the budget was already set for the year, and they had to say, okay, so I graduated in 2014 and I did my NIFA program in 2015. That's pretty common. Okay. I also know people that have used CME money for the first couple of years in exchange for saying, I'm going to guarantee that I will work here for X amount of years, just kind of guarantee that the training is not basically I'm going to learn and then leave. So be aware of that. Realize that training takes time and money. There's no one or the other. It takes both. And your vacation time is something you'd be thinking about. Make sure you do everything possible to identify this as a unique skill required for your job. I mean, I interviewed at the same time for family practice and CV surgery, which makes no sense, right? So it's like, well, even the surgeon that interviewed me was like, why are you interviewing for family practice and you're also interviewing for CV surgery? It doesn't make any sense at all. Because a surgeon, of course, they're going to say, you're silly to do that. Well, for me, it's a backup plan. I would like to do both of those. It was an awesome family practice physician I did training with, but I really think my dream job would be CV surgery. If you're not willing to wait a year for me, that's fine. I would be happy to go and be in this healthcare system and work in primary care. But I need you to know that that's going to take more training if I want to go do the CV surgery job. I don't need to be an RNFA if I'm going to be in family practice. And they said, okay, I think we get it. We'll have to, pay for this if we're going to do this. So it was important that I said that, because otherwise I've seen people after me in the same facility not get it and be forced to use CME money and pay out of their pockets. And, you don't need that skill if you're not doing the job that they're hiring you for. So they should be paying for it, in my opinion. And they'll get their money back out of you because you'll be more efficient, provide higher quality care, do better skills. It just makes sense. This is kind of a fun picture showing some stuff at Skills on Point, which is the company I was talking about. Upper left-hand corner is learning some ultrasound guided IV stuff and some central lines in our sim lab. This is just some kind of fun pictures up here of some of our course content. We make a lot of supplies. We do a lot of conference materials for a lot of different national conferences, and we have a lot of courses that get sent out to students directly where they're at. This person in the far left bottom here, she's actually a CV surgeon, and I want to say somewhere in Central America, and she came up to learn how to do vein harvesting at our sim lab. She herself, again, a CV surgeon, obviously you think she know how to do that. And she said, yeah, we don't do anything endoscopically, but I'm going to be working in the US. I have to go reboard and everything to be here, but I just want to learn how to do this the right way because we do everything open instead of endoscopic. So down the bottom right here, these are actually some NPs that are going through some central line training at a NIFA workshop in Las Vegas. And just some more gear and some fun people hanging out. And you can tell this bottom left picture is certainly pre-COVID, back when there were no masks and social distancing didn't agree and all that. But that said, it's all a matter of having access to high quality training materials and the right environment and time. It's super fun to see people go from where I was at, where I felt like I'm brand new to this. I don't really know what I'm doing. I'm trying my best, but I feel like there's something I'm missing and I don't know what that is because you don't know what you don't know. And my goal with what we're trying to accomplish here is I want you to understand what it's going to take for you to do the job of being an APRN in the OR. I want you to know you have resources. NIFA is by far the difference in my career from going from being a lefty that went into CV surgery with a surgeon that said, if you're not a right-handed person, I don't want you in this job. And they said it was like straight face. And I'm like, wait a minute, can you say that? Can you do that? Because like, isn't that discrimination? And he looked at me and said, no, I mean, we're gonna be bumping hands the whole time. So you need to learn how to suture right-handed. So I went to NIFA learning everything from scratch. And I had to say, I'm going to do this right-handed. And after about 3 or 4 days, it really started to click. And I can tell you that nobody knows that I'm left-handed in the OR because I do everything right-handed. It is what it is. The training was able to get me there. Whereas otherwise I was getting nowhere on my own. So point being is that training is valuable. It's going to make you better. If you have the option of it versus not option of it, invest in yourself and do it. I think you'll find it's very well worth it. And if there's opportunities where you just want to grow and do additional skills and things that are more privileging and credentialing stuff, check out Skills on Point. We'll hook you up. We'll get you all the stuff you need to make sure that you have the skills that match your first assisting with all the privileges and procedures that you may do, whether in the OR or outside the OR. Okay. With that, I'll say any questions that you may have, I'm happy to take. That's okay if you don't have any too.
Hey, John. My name's Andrew. Can you hear me?
Yeah, I can hear you, Andrew. How are you doing?
I'm doing well. How are you?
I'm doing good. Thanks for being here.
I was just wondering if there was anywhere you'd be able to drop your email. I have some specific questions that I'd rather ask off of this.
Well, it's interesting you mentioned that. I will specifically, put up a screen here right now so that you can see that. This is my info right here. This is my cell. Feel free to text me, call me, whatever. I'm more than happy to be available to anybody who has questions. It's john.russell@aprn.com. We'll get you a hold of me. Or if you go at skillsonpoint.com, feel free to just use the chat feature on there. It'll go right to me. And also, if you are on their online CE portal, you can get 30% off all of our courses right now if you use the coupon code SWEET. So it's a little something special to say thanks for hanging out with me tonight. So either way, here's the info. I'll leave this up here. If there's any other questions, feel free to use this and write this stuff down if you're wanting some more private question answers, which I'm happy to do. Anyone else?
Hey, John.
Hey.
Hi, my name is Jillian. I'm actually also a nurse practitioner in CT surgery.
Nice.
So I actually had a question regarding, because you were saying that your wife was one of the first nurse practitioners in her hospital to be in the OR. So my last hospital solely used NPs, PAs, residents in the operating room. And my new hospital actually only uses surgical technicians. And so I guess my question is regarding kind of who to get in touch with, who within the hospital would be the best to try and bridge that gap, given the fact that, you know, we can bill CMS and commercial.
So what kind of hospital is it? What kind of priority? Is it more like ortho, or is it just general surgical or critical access?
I would say it's probably more general.
Okay. Metro?
Yeah, yes, it's definitely Metro Hospital.
Yeah, there's definitely some thought that it's cheaper to have an STFA than to have a RN or an APRN-FA. And in some regards, and here's the other side of that, right? If the hospital has done a really bad job of negotiating for their insurance products, what you'll find is there's only so much you're going to get for adding an assist to the case, right? So you can do 10 cases in a day versus 11 cases. And if you have a really good first assist, then maybe you go from 10 up to 12, right? So it does make a difference where you can tack another case on. But if you're doing CV surgery, or you're doing something that's going to be like, you know, maybe 1 or 2 cases, and that's probably it for the day, it doesn't really make that big of a difference for having like a total rock star for turnaround. So you're not really going to make a lot of money on the shake and bake of getting the room flipped. So where is the value add? Well, I think the biggest value add is the continuity of care. So if you're going to talk to anybody, to me, it's going to be the CMO, the chief medical officer, or maybe if you have a really good CNO, the chief nursing officer, depending on how they really vouch for, or they really push for that nursing governance and trying to have, you know, some kind of relationship there. I think it's a 50-50 shot on the CNO. But the CMO is usually the person that has to deal with when the care isn't really as quality and what can happen. And the nice thing about being an NP, if you're in the hospital, is if you're in the operating room and then there's a problem afterwards, time and time again, the person you want to call is somebody who is in the case and is going to know what the problem was to fix. So that's one of the biggest things that you can add, is that perspective. And if there's a problem, you can be the person that gets the phone call and the ability to do the daily management, the throughput. You just have a better understanding for patient education. Whereas otherwise, you're just not really in that role. They're just not going to be utilizing you the same. So they may not be able to bill for you and add a lot more value because their insurance products maybe are just terrible, or maybe they just didn't really negotiate them very well. I know, for example, like for me, CV surgery at the hospital I'm at, it adds like $7 if they add a first assist bill to some insurance products. And if I was to do a standalone, you can bill a couple $1,000 maybe for a vein harvest and assist and all of that. So if your insurance product is like, here's your bundle, have a good day. I don't really care if you have a first assist or not. It's not really going to, add any complexity to it. So it is what it is. The hospital may say, well, why would I pay all that difference in having, NPs or PAs when if I get $7 a case in the course of a year, say we do 300 hearts, that's, very, very small potatoes, a couple $1,000 we're talking about, comparatively speaking, to the cost difference in salaries. So where you're going to show that value add is in the longitudinal care, the complexity management, the risk stratification, and then taking that patient through the process by their hand. I think that's really where you see the value. And that takes someone who gets it from a big high level picture, and CMOs tend to be in that position because they're forced to deal with all the things that go wrong. They're kind of like, the judge of dealing with all the surgeons and the physicians that have bad attitudes or bad outcomes. And they're always part of that process of saying, hey, we got to do this a little better. And I've seen them really be able to step up and vouch for NPs. So that's just my 2 cents.
That's fantastic. Thank you so much.
Yeah, gosh. And I'm not the only opinion here. If there's other people that have anything to add to that, feel free. But thank you for your question. What other questions you got?
I have a question.
Yeah.
My name is Michael. I'm a nurse practitioner in Arizona, and I have my own practice, and I refer a lot of surgical cases out for orthopedic, joint, and spine related procedures, surgical.
Sure.
And I'm trying to create some relationships with these surgeons so I can be able to assist on my own cases. How would you recommend, beyond what you've already discussed on the bundles, that maybe I would negotiate with some of those surgeons to be able to capture assisting fees on cases of mine that ultimately go surgical?
Oh yeah, so that's a great question. So it's really the ultimate double dip, right? If you're, for one, you'll have to be credentialed where they're doing the cases and with the insurance products that they're going to be using. But let's assume you are for both of those. And if you have your ability to say, look, I'm not going to cost you anything. I'm just going to speed things up, unless they already have a first assist or if they already have a team or, whatever they're doing, who knows? Let's assume that they're just doing 2 surgeon or they're just, rocking it out and they really wish they could have a first assist. And you're like, hey, I'm raising my hand here. I could be that person.
Yeah, let me jump in there. That is the case. They don't have assists, and I do have time, and I do send them quite a few cases that ultimately go surgical. And it's all orthopedic related stuff. So most of them, I think, would qualify. But I'm just curious, and all the insurance products already on the same plans and credentialed at the same facilities. So just trying to, better understand maybe how to look at that from more of a business perspective.
How to market that, really, yeah. So how do you market that in a business sense, right? So yeah, I mean, if all those variables are gone and it's really just saying like, hey, let's go. If you're already in the same healthcare system as them, do realize that it may be a little bit different. But if you're talking about as a standalone owner of a business, and you're not really employed by a healthcare organization, you are
correct. And we're going to ASCs in healthy populations.
Gotcha. Yeah, I mean, you are going to be able to bill for your services independently, and there's different ways you could approach that. If you know the repayment for those cases is a first assist. Let's say you're doing, gosh, I don't know, if you're doing, anterior cervical discectomies, it's going to be a couple grand a case, right? If you're doing APPs, it's not going to be a couple $100, right? Every case is different. So if you know the value add for those different billable cases, I think you need to just have a conversation and say, here's what the value add to the actual final bottom line is going to be. If I come in as a separate entity, and you could say, hey, you pick me, I'll give you X amount of dollars for every case just to be there. Or, you pay me X amount of dollars just to be an extra set of hands. And then I bill for myself. All you have to do is just say, I was an assist on the case on the record. That's all you have to do. And I'll take care of all the paperwork, no extra headache. It's going to speed up your OR times. It's ortho, volume and speed is everything as long as quality is there. So if you can help expedite the process, why would they not want to? But I think that's really, you have to get creative. You have relationships with those people. A big part of that is making sure that they understand that you're not trying to take away money in the process. If you can just add money to the pot by speeding up their day, why wouldn't they want you there? I mean, that sounds like a no-brainer.
Yeah. Well, when I went through my NFA training, I assisted with these surgeons because they've already trained me, and essentially I pitched them that I'm an extension of their practice. They get all of my surgical volume, and it's prepped and ready to go. You just need to, ultimately put your final blessing as whatever you're going to do surgically on them, because it's your decision at the end of the day. And they've been, so far, that's okay. But I just completed the training, and now I'm in a position where I need to better understand the billing and the financial business relationships that occur here. And so,
do you have a billing company that you use for your primary stuff?
I do, yes. They are not skilled in surgical assisting.
Gotcha.
Billing, though, general medical.
There's another NIFA webinar that I would encourage you to check out. It's with Gary Hargreaves, and he is very involved with the NIFA billing company. And whether or not you would use them or another product, certainly it's up to you. But he would be a great person to just ask that question to, because he may be able to direct you to someone locally that would be a resource if they're not in that space. But if nothing else, it would be a good person to talk to get the ball rolling on that. They would know what the options are. But it sounds like you're in a perfect position because you're not hospital owned. So you're not going to be stuck with the assignment. Assignment is everything, right? So I can only bill $7 because I'm in the same insurance as a part of the assignment that you're going to get for Medicaid for this case. Whereas if you're standalone, you can bill standalone, right? And that's the best case scenario. So I think you're in a good position to retire early if you play this right.
That's great.
But, you just have to make sure that you have a good biller that understands that the best thing you can do is get that bill out there ASAP. The first person that sends the bill in is the first person to get paid. So make sure that you are the early bird with that.
Understood. I'll probably be emailing you some additional questions if you don't mind.
Feel free. My pleasure. Glad to do it. I'm excited. It's cool when you see entrepreneurs that are, the more NPs that are owning their own practices and recognizing this is something you can do. There's plenty of margin here where you don't have to work for a hospital and you can still do this job and you can do very well with it. You just have to be comfortable with the concept that you may or may not see as much volume and your paycheck's not going to be the same every week. But that said, sometimes it's way better. So that is an okay problem to have. What else you got?
Hi.
Hey.
Hi, my name is Christy.
Hey, Christy.
I'm an RN in the OR, not an NP, and currently about to begin my the course 2 clinical portion of the program.
Awesome.
But I have been doing some research and kind of learning, and like you mentioned earlier, kind of navigating the entire process of how you want to shape your practice and future potential practice. And so you mentioned earlier that when it comes to billing an RNFA, when it comes to billing for cases, the op report has to mention either if there's a resident available, an RNFA cannot be billed as a first assist. Does that apply for FMPs that are hired directly from the hospital, and also does that apply to RNFAs hired independently of an academic institution?
So that's a great question. I would say there's two ways to answer that question. One is it's specific for residents because the hospital is getting money to have those residents be that person, basically.
Understood.
So if you don't have a training hospital, right? If you don't have that academic institution, it doesn't really matter. FNPs, not really an issue because there's no money that the government's paying FNPs to be there or any other PA it doesn't really matter. It's only just those residency programs usually where they get money coming in. But as far as your ability to bill for them, really, as long as your name is on the record as the assist, that's all that matters, period.
Oh, so if it is at an institution with residents and fellows, an RNFA can still be billed on
as long as they document that there was not a resident available for the case.
There was not a resident available.
Right, because they're saying, hey, you should have used the free help first, right? Why didn't you? Oh, no one was available. Oh, okay, fine. Then you can bill for you. Otherwise, that would be like trying to double dip the revenue. That makes sense?
Right.
So that's why they do that. But again, if that's only something you'll see at academic institutions. Otherwise, if you don't have those students or if you don't have, those kind of residents there, you just will never see that documented. And people are like, why are you putting that on there? It's like, well, because obviously you must work somewhere that we have residents, and it's just part of the process. So it's a great question.
Thank you.
Yeah.
And so moving forward, I'm sorry.
Course 2, huh?
Yeah, I'm so excited.
Yeah, it's good stuff. It's so much fun.
When becoming or adding on the FNP portion of the planned career path, now that would still, well, no, now would an FNP RNFA still be billed as an RNFA or an FNP in the OR?
So that's a good question. So the RNFA or the APRNFA are the same thing. It's just whatever your certification is at the time of doing it. It doesn't really matter. So you've gone through the first assist training, you're assisting in the OR. NIFA is training you to be an assistant in the OR. It's like if you have a bachelor's of nursing or if you have an associate's of nursing, you're still sitting for the same boards for the NCLEX. Does that make sense? So same thing happens here. I don't care if you're an RN or an FNP, you've gone through whatever the qualifying is to sit for the boards, so to speak, for this, which is basically to first assist and go through the training. If you're an RN, you have to do very different specific things, like you have a BSN and have your CNOR and all those things, right? But if you're an FNP, you don't have to, just because you've gone on for a couple of additional years of school at minimum. So they don't require the same exact thing. But do realize that it's the same thing all said and done. If you're an RN, you get an RNFA, and then you decide to become an FNP, yeah, no, you're good to go. You still have gone through a formal first assist training program. It's no different of a program for a nurse than a nurse practitioner, except for the amount of experience you bring to the table and perhaps which course you would have gone through for the 3 or 5 day course. But really, at that point, you're good to go. It's not no one's going to ever say, well, wait a minute, you were an RN at the time. No, they don't care.
Okay. All right.
Great. That's a really good question.
Thank you very much.
Yeah, my pleasure. Great questions.
Hey, John, it's Andrew.
Yeah.
Hey, I got a question for you. I'm RNFA right now since 2018. I'm about a year or so until done with a acute care nurse practitioner program.
Very cool.
And I have a agreement basically lined up with a general surgery practice to be an NP with them when I'm finished under the hospital. And they don't currently have anyone there. I work with these surgeons all the time at the hospital. What advice or what should I focus on, I guess, to make that transition better? I mean, I'm closing and stuff for them now.
Yeah. So
what advice you got?
Yeah, great question. I would say the best thing you got going for you is that you already work with them. They already know you. You already know them. The question of whether or not you're going to be a fit has already been answered, right? So that takes all that stress away. The things that you don't already do, once you're done with the acute care, you should have that training, right? So the central lines, art lines, maybe intubations or, drains or, whatever it is that are specific for gen surgery. I'd say most of it is going to be simple things like when your patient has a septic belly and or like a dead gut or something like that, or the perf viscous, and they look shocky, and you're thinking, I need to put an art line in, I need to put a central line in, I need to resuscitate this person, get them on pressors. Those are the things that I would make sure that you're really fluent in. And whether it's the skills or just the knowledge of how do you do good, ABG interpretation and fluid management and, that kind of stuff. Those are the things that I would say, if you are really up on that, and ask them in the meantime, hey, what do you guys envision this looking like for me working with you? Because I've got some time. Now is my chance to do these additional trainings and make sure that I am spot on. I would say the biggest thing you can do, and I'm not trying to toot the Skills on Point horn here, but find a company that works with you as far as, making sure those skills are spot on. So if you want to come to Skills on Point, we'll train you. Go find somewhere else too. I don't care. Just find somewhere that is going to give you a lot of competitive edge on being awesome at art lines, awesome at central lines, awesome at ultrasound. Those are the things that are really going to make you stand out compared to anybody else, and make sure that you are ready for that, because that's not going to be taught in school as much as you would like it to, unless you have an absolutely awesome clinical. SimLab is great and all, but that said, you're only going to get 1 or 2 rounds through some of that stuff. Whereas if you can just really spend a whole day of dedicated just diving in on that, it really just, it prepares you better for clinical, and you'll get more out of the clinical that way. So that would be my advice. And again, it sounds so very biased to say that, but just see through that and understand what I'm saying is like, you really got to get those skills down if you want to be comfortable. Get a whole bunch of cases doing that, because when you got to go get credentialed at the hospital, that's the biggest thing is they say, okay, well, here's this person brand new to the system. They've never been here before in these roles, but they have it in the OR. Okay, fine. So we'll give them the assisting. That's fine. What other privileges are you requiring? Well, he wants to be able to do central lines and chest tubes. Well, has he ever done any before? Well, he's done 2 in clinicals. Well, that doesn't really count, right? So I need to have you do 5 more. I need to have you have proof of this training and that training. It just puts more hindrances in your way, right? It's just hurdles. And it doesn't mean you can't run through them. It just means that you have to plan for them. So I would just say that's the smartest thing you could do is say, hey, while I'm a student, don't just force me to learn the stuff in the OR. Also take me out on the floor, teach me those procedures, teach me the things, and let me go do some standalone training, get an independently credentialed continuing education certification in it. Like you come to a acute care, procedures course with us, it's 8-hour a day of all kinds of stuff. Those are the things that people take that certificate, they hand them to the credentialing committee and they say, oh, you've already done above and beyond. So here you go. Here's your credentials on it. Have a good day. That would be about the one thing it doesn't sound like you have for sure. And maybe your acute care program will provide that, but don't be surprised if it's not as robust. It's kind of hard you kind of have to self-direct that stuff, I guess.
Yeah. And I've, been in the OR, they're, prepping these patients and stuff. Anesthesia, we work with a bunch of CRNAs and they want me to do anesthesia, but I'm not into that. And, I've done several intubations, and if we have an art line, I'm telling them I want to do that. And
good.
I've probably got about 4 or 5 of them under my belt. So
great. That's awesome. Keep doing that. That's the smartest thing you can do. Get comfortable being the person any time of day, as long as you have a training agreement and they're going to let you do that with the clinical personnel that, you have working with you. Do as many as they'll let you do. That's the best thing you can do. That's awesome.
So last thing is, so I know with being an RNFA, I have to keep CNOR up every 5 years, but I'm hoping I'm done with my acute care program by then. What's the upkeep? Do I have to have the upkeep for the RNFA, or once I'm NP, there's no more upkeep, or what?
Yeah, once you're an NP, you're done. You just have to keep up your certification, and then I would encourage you, if you have the opportunity, to go on and get the certification as a CRNFA, just because it helps to, people are like, well, why as an NP would you go get a CRNFA? That's more of a RN thing, just for saying you can work in your specialty. If you're in the OR, if you're a first assist, you should get a CRNFA. Well, as an APRN, people are like, it's stupid, don't do that. That's actually not true, because that just helps, it helps show the value of certification, and it helps show the value of kind of a unionization of that skill set. So we're all kind of on the same page with it. And everybody that can go through and say, look, we do add a vital service. I don't care if you're an APRN or an RN. I'm certified. I can be independently verified by experts in my field and tell me that I do meet that grade. So I would encourage you to get the CRNFA. You don't have to as an APRN. But that said, after a couple of years as an RNFA, it is encouraged. But that said, you don't have to as an APRN, but I did. I would encourage you to do it.
Thank you.
Yeah, thank you. And thank you all. It's really nice. These are great questions. It's what we're here for. We're all learning from each other. Any other questions?
Hi.
Hey.
This is Chrissy. Another question. So circling back or piggybacking off that, my last question about residents and RNFAs and POR. So given that the op report needs to declare that a resident is unavailable, which required an RNFA. So requiring a resident wasn't available can be interpreted, correct me if I'm wrong, can a resident being unavailable be interpreted as requiring an additional assist? for a case, depending on
I think I understand your question.
like depending on the need of the case. If
Yeah,
it's not
and
just,
that's where it comes into
it requires
what
more
case
than
is.
just a physician, fellow, and
Yeah, and
resident.
they're probably still going to bill for them as opposed to billing for. There's probably going to still bill for them as opposed to
Correct.
billing for you. But that said, if a patient is that sick that you have like multiple assists, really it's just going to be with first assist billing, period. It's not like with 7 first assistants because it was massive transfusion protocol and the patient was bleeding out. Like you can document that, right? But you're still only going to get like 1 assist, modifier on the billing usually. So I would say talk to your billing people if that's a very unique scenario, but I do not anticipate that scenario is pretty common. I think the most common thing you're going to run into is like, do you have a resident available? Yes or no? Okay, yes or no. And then what was the case you were doing? Let's say there was no resident ever available. You're not in a teaching hospital. You still have to verify that the case is something that requires an assist. And the surgeon still has to do their job in documenting what the case is and the complexity and why you are needed. It's kind of a lax thing. And some surgeons, they say, well, this case obviously always assistable, so who cares? But that said, there are some that are like, yeah, I'm just like a hernia repair, but I also had to do this and had to do that. And oh my gosh, it was complicated. I had adhesions, and that kind of stuff is all it takes, a good surgical note to take care of for you. And as long as your name is listed as a first assist, you can bill. Now, again, the billers are going to bill for you. If you're within a hospital system and you're already in the system, you're not going to be billing independently. You're just putting in your own little separate peri-op note. But if you are your own billing, if you're your own company and you're doing that as a, like Andy's talking about, I remember it was Andy, I can't remember his name, from Arizona. And he's talking about, he's got his own company and he's going to work as a standalone RNFA or APRNFA. And that's totally different, right? Because they're not owned by the hospital. It's a different person. Then you're going to be billing specifically. That's probably even more important to make sure that the surgeon has done a really good job of saying, hey, why did I need to be here today? Well, because this got really weird. We had some problems and this is what happened and blah, blah, blah. Just make sure the surgeon's not shortchanging the case and then potentially not letting you get billed for it. That's the hardest part, right? Because you can't control what the surgeon writes or doesn't write. But you certainly can encourage them to say, hey, just so you know, I wasn't able to get reimbursement in this case because you didn't do a very good job of saying why I needed to even be here. And this is a pretty complicated case.
So working or billing independently or billing with alongside a group, either way, an RNFA needs to be documented on the app report.
Correct.
And depending on reimbursement will require the surgeon to have an op note describing that a first assist was required or a resident was absent, regardless of the kind of circumstance or whatever.
If it's in the gray zone, yeah. But let's say you're doing like an ECMO case or something. No one's going to question it, right? Because it's an ECMO case. And the billers, they get it, right? They understand the complexity of it does warrant it. But there are some cases that are like, yeah, if you're going to ask for an assistant on a central line placement, I'm going to say no. But, well, if it actually was a cut down and the patient was, had like a woody tumor or something, and like in their vascular cancer or something, and now they're basically having CPR in progress, like, okay, different story, right? So just, it's all about the documentation. And that's really where having a conversation with like Gary Hargreaves or something, just say, hey, what would you say? They're the billers, they're the experts. I'm just telling you what my experience is, but I can tell you that they have experienced so much more. And it does vary based on insurance product. Some products are kind of like, yeah, whatever, you can have an assist. Some of them are like, nah, no. And the same exact document, same exact patient, same surgery, CPT code, everything. It just is depending on how the hospital is negotiated with them.
Okay. So how would you recommend an RNFA become more familiar with independent billing?
Talk to a biller or coder and make them like your best friend, because they love billing and coding. They know it so well, right? That's like the expert. And they love it when people appreciate the art that they put together. They truly, it's an art to actually do really good billing. And if they tell you, okay, so here's what you could do better. And honestly, it starts with the conversation saying like, okay, I need to have some independent billing. Like, okay, so now they're bought in because you're going to bring in some revenue for them. And the flip side of that is you can say, and how do I do it best possible so that we both make the most possible money of the revenue that I am owed for doing this case instead of fighting for it? They can tell you all the tricks, things that I, they know exactly what the different insurance products in different states, what they will and won't cover. That's their expertise. That's what I would say.
All right. Would it be reasonable for someone to begin? So if an MPI number is already established, would it be reasonable to begin preparing your contracts with insurances ahead of time?
I would say it's never a bad idea as long as you know what you're doing and have, I would say if you're going to go through that process, you can spend a little bit of money and have an expert do it, and it all goes much smoother than if you do it yourself. Some of those are not difficult, but some of those, there's quirks to them. So again, the billing companies, they would be the people that would know the best way to do it. And some of them will say, yeah, for $500, I'll get you credentialed in like 7 different insurance products or something. You're like, oh, well, if that's the case, like take my money, you know, where do I sign up, instead of spending all kinds of time and waiting and you did one little thing wrong and now you're not going to be able to. And like, you know, they're the ones that do this every day for a living. Trust them to do their job. They're the experts.
Yeah.
They want it to work, right? Because then they don't get paid either if it doesn't work. So they are the best people to ask. It's like an accountant. Like, who really wants to be an accountant? An accountant, right? Ask
no, but it's always good to be familiar with what you can and cannot do, especially with all the virtual roles now. So
yep. And a biller that really gets it and a coder that really gets it. Both of those are two very separate things. They love talking shop. If you're interested in learning, they always love teaching.
Okay.
Absolutely. Great questions. Thank you.
All right.
Any others?
Yeah.
Well, thank you all for attending. I had a lot of fun. I hope you did too. Like I said, this is my contact info right here. If you need to get a hold of me, feel free to shoot it out. That's my cell. You can text me, whatever. John.russell@aprn.com will get you to me. Go to skillsonpoint.com and just send me a text in the contact us feature after hours, you know, or during hours, whatever, doesn't matter. Just 24 hours a day, shoot something out there. I'll get back to you. And if you go to the Skills on Point website and go to the top menu and click the online CE portal button, it'll take you to all of our online courses. There's tons of stuff in there. There's a course in there I really recommend. It's called Interviewing and Negotiating for New Grad Nurse Practitioners. It's $12. You know, it's not a big expense course. And with the 30% off, it's even cheaper. So make sure you use that discount code SWEET and save some money. But that's the kind of stuff that's designed to help you be more successful. So feel free to take advantage of that. We're here for you at NIFA, and we're here for you at Skills on Point. We're all in this together. Thank you for your time. I hope you had a good time. I know I did. And if you have any other questions, feel free to reach out. Otherwise, I will let you go. Have a great night.